Hi, my name is Clinical Gladys and you're watching a video on the characteristics of partially accommodative esotropias. So in this video what we're discussing is an esotropia that's accommodative and constant. This is a partially accommodative esotropia. And hypermetropia is the contributing factor to the disorder. What this means is that when you correct the hypermetropia, you will partially correct the deviation or the esotropia. You will not be able to fully correct it as you do in fully accommodative esotropia, only partially, because hypermetropia is not the sole reason for the deviation being present. There are other factors there, anatomical, static, kinetic factors that are leading to this deviation, but part of the etiology is hypermetropia. It's also worth noting that patients who have a partially accommodative esotropia may have been patients who previously had an intermittent accommodative esotropia. So they may have had a fully accommodative esotropia or a convergence excess accommodative esotropia. In which case, over time, what's happened is that it's become more constant and the patient has developed a non-accommodative component to the deviation, meaning that even with full correction of hypermetropia and or with any bifocals, if it was a convergence excess esotropia, the esotropia now persists through that correction. These patients usually have good potential for BSV because they were once intermittent and had a longer period of time of BSV. Other patients may have had smaller angle strabismus when younger, and as they've gotten older, they've developed an accommodative component to this strabismus, and it's increased in size, and this is usually the time that these patients present to the clinic. These patients tend not to have as good potential for BSV. Okay, so as I mentioned, what we're expecting is that the patients are going to have hypermetropia, and that hypermetropia will partly correct the esotropia. So if we have a look here at the image to the right, you can see that the patient has an esotropia here, and then with the hypermetropic correction, we can see that there is an esotropia here, but it is smaller in size. That left DT there is larger without correction than it is with correction. And you should see at least a 10 diopter shift from without correction to with correction. Now, generally, most of these patients will have a basic angle deviation, so very similar near and far, and therefore a normal ACA ratio. However, some of your patients will have a convergence excess pattern with a high ACA ratio, which means that with the glasses on, for instance, the deviation will be smaller with the glasses on, but will be larger at near as compared to far. What distinguishes this patient from what we classify as a convergence excess accommodative esotropia is that this patient has a constant deviation with full correction. If in doubt, the patient with a partially accommodative ET will not respond to bifocals. When you give the patient additional plus, they do not attain BSV. A patient such as this should still be classified as a partially accommodative ET with a convergence excess pattern. You shouldn't call it a convergence excess accommodative ET. When you use that term, or when you use the term non-refractive accommodative esotropia, it is assumed that the patient has an intermittent deviation. So to be clear as to how you're classifying the patient, make sure that a patient with a constant deviation, which is smaller with the glasses on, that has a convergence excess pattern, is classified as a partially accommodative ET, but you can then go on to say with a convergence excess pattern. Now, because it's a constant deviation, these children will generally be amblyopic and binocular functions will be absent. However, some patients will have the potential for BSV if the deviation, for instance, was intermittent previously, or if the deviation occurred at a later age. Okay, that brings us to the conclusion of this video. Thank you for watching.